Welcome back to Therapeutics. In this block, we're going to review the principles of therapeutics related to upper gastrointestinal conditions, and next week we'll wrap up GI with lower GI therapeutics. We'll focus, in addition to some of the exocrine pancreatic issues, gallbladder disease, liver disease, and liver failure. So when we think of upper GI, there are a number of medications that have specific activity in the upper GI tract. We have agents that suppress acid secretion. The most effective of those are the proton pump inhibitors. We also have the H2 blockers. And not so much acid suppression of secretion of acid, but neutralizing of acid are the antacids like Maalox or Mylanta. We have agents that protect the gastric mucosa by either binding to an ulcer site or an early ulcer site like sucralfate, or by affecting prostaglandins that affect the mucus level in the GI lining, particularly the stomach lining. Those include misoprostol, which is, and misoprostol is an agent we'll talk briefly about. We don't use very much, at least not in GI therapeutics, but it's still available and people may occasionally use it. We have a number of agents that increase upper GI motility. Included there are metoclopramide and the macrolide antibiotics, particularly erythromycin. Erythromycin we don't really use that much as an antimicrobial anymore, partly because we'll largely replace it with azithromycin or one of the other macrolides, which has maybe a slightly better GI tolerability than erythromycin. But occasionally when we have somebody who has significant GI motility slowing, we'll actually look at increasing upper GI motility with erythromycin. And one of the last groups we'll talk about in this block in upper GI are the antiemetics. There are a number of them that are available. We'll talk about them here. We'll also talk about them again when we talk about management of patients in oncology, where the chemotherapy, many of the older chemotherapeutic agents we use are highly emetogenic. Of the antiemetics, we'll talk about dopamine antagonists. We'll talk about serotonin 3 antagonists, some of the antihistamines, antimuscarinics, and a host of other agents that can be used as well. Let's first now talk about acid-suppressing agents. Those are the proton pump inhibitors, are probably the most effective there. The classic agent we think of initially is omeprazole. There's lots of other proton pump inhibitors, but omeprazole or Prilosec was really the first one on the market a couple of decades, 2-3 decades ago. It's probably the highest in efficacy. All of the proton pump inhibitors are highest of all of the types of GI acid suppressing agents. And most of the PPIs are considered more or less interchangeable if you pick the dose that's considered an equivalent dose. For the most part, proton pump inhibitors don't have a lot of short-term side effects. We will talk about some longer-term concerns. We see concerns, particularly over the last 10 years or so, concerns evolve around B12 absorption variation. We see potential risk for carcinogenesis, carcinogenic issues. And here's the issue, probably that cancers associated with PPI use isn't so much, I don't think, that necessarily that the PPIs themselves are associated with carcinogenic nature, as they may be. It's pretty easy to, instead of getting somebody who has GI upset, a full GI workup, to just put them on a PPI and see if they feel better. And when we don't get a full GI workup for somebody who has gastric pain, there's at least the risk that they have gastric cancers. And so we just want to be careful about not treating a condition with a PPI that masks some important other issues that we should be addressing. How PPIs work, they really are converted to their active drugs, so they're prodrugs, converted their active drug in the parietal cells, and they cause an irreversible inhibition of hydrogen potassium ATPase pump. That affects basically basal and stimulated acid release. And so we see that these agents begin to have their effect in a few hours, but they really don't have their maximal beneficial effect for up to 24 hours. Now, when we say that it's an irreversible inhibition of the hydrogen-potassium ATPase pump, that's for the life of that pump, but those pumps get regenerated. And so really these agents are very effective, but after 3 or 4 days, after you stop therapy, you produce more hydrogen potassium ATPase, and as such, it's irreversible for the life of that pump or that enzyme, but it's not really irreversible for the life of the patient, just for a few days. So let's look at omeprazole a little bit. It's absorbed orally. There's also other PPIs that are given parenterally. It's metabolized hepatically, but primarily excreted renally. Typically, we see its use both short and long-term. Most often, the short-term use for an upper GI bleed, and the longer-term use primarily for folks who have gastroesophageal reflux that's not responsive to other concerns. The short-term side effects, headache, maybe a little GI upset, interesting that some patients have, even though they generally improve things there. Occasionally, patients will have it. Omeprazole is dosed typically 20 to 40 milligrams orally once a day. There are a number of them that are given. Almost all of these agents are dosed early in the morning, or sometimes we give it twice a day. Here are some of the PPIs that are on the market. There's omeprazole, esomeprazole, which is the active metabolite of omeprazole. There's lansoprazole. There's Asphex, which is rarely used. I don't see that used much. Protonix, pantoprazole, commonly used. And sort of a few other agents listed at the bottom here. For the most part, they're really interchangeable, and the decision of which proton pump inhibitor you're going to use is going to be a function of what's on your hospital formulary or your, if you're an outpatient setting, what the insurance covers. The only ones that are over-the-counter are omeprazole and I believe pantoprazole and lansoprazole have some over-the-counter availability as well. There's a few other alternate ways that we can think, or alternate formulations that people will use when somebody can't tolerate oral therapy. If you have to open up a capsule or mix it in something, they don't maybe tolerate capsules, but they can have to give it, for example, via a G-tube or a J-tube or something like that. And so there are different formulations that are done. We don't necessarily want to open up a capsule and just mix it in the product if the product's not stable to do that. So we just need to be careful about how we administer some of these products. The recent concerns with the PPIs, although they're well tolerated, we've had now a couple of decades of use. We are concerned about when we have excessive acid suppression in the GI tract, the risk for pneumonias, particularly aspiration pneumonia is a concern, but we see other pneumonias as a potential risk. And here what happens is that the acid actually affects the gastric flora in the upper GI tract. If someone aspirates a bit without acid suppression, lo and behold, they could have more bacteria in their stomach for which they aspirate that and pose a risk. So we have seen over the years data to suggest that folks on a PPI have an increased risk for pneumonias. There's also some question about longer-term risk fractures with PPI, so we're aware of that. There is a clear risk for C. diff. And so of all of the agents that we use in GI to decrease GI acidity or to affect gastroesophageal reflux, the PPIs are the worst for predisposing to C. diff. And the mechanism of why that is probably that the spores for C. diff are probably inactivated by gastric acid. And the more aggressive that acid suppression is, the more likely that C. diff is going to become colonized or infected in a patient. We also worry about the risk for changes in magnesium, so that's a concern. And there are a fair number of drug interactions that occur with the PPIs that might affect some of the drug metabolism. Most importantly, with omeprazole, for example, is the interaction between clopidogrel or Plavix and omeprazole, where we inactivate the ability of Plavix or clopidogrel to be effective. And for folks who have a deficiency of cytochrome P450 2C19, and that's about 3% of the population or so. We're concerned that actually the combination of a PPI, particularly omeprazole, with Plavix renders Plavix not active, and therefore if somebody's got a stent or they've got some other major indication for using Plavix, it doesn't, the Plavix is not going to be effective, and they risk a formation of a clot or a thrombus. Some of the adverse effects that are listed here we've already briefly talked about, but this table kind of goes through that in a helpful way, is some concerns about whether or not there's a fracture risk. So we want to make sure at least that bone mineral density screening is done for folks at risk for osteoporosis. You want to evaluate magnesium levels in folks who are on long-term PPIs. C. diff, we really want to evaluate, does the patient really need it? Limit the dose and the duration. Are they a candidate for an H2 blocker, which also probably has some risk for C. diff, but lower risk than a PPI does. And whether or not there's a risk for community-acquired or healthcare-associated pneumonia. Let's now switch gears to the H2 blockers. These are older group of agents, but they work pretty well. They don't work quite as effectively as the PPIs at acid suppression, but they're pretty good at that. And they, ranitidine, cimetidine, and really the one we see most often used now is famotidine. And these are widely used agents still. They've kind of made a bit of a resurgence in the last 4 or 5 years with the concerns associated with proton pump inhibitors, particularly related to C. diff. And so we'll see sometimes these agents used in place of a PPI, particularly for patients in settings with a lot of antibiotic use where we'll worry about C. diff development. Famotidine affects as a blocker for histamine 2 receptors located in parietal cells, which therefore reduces the secretion of gastric acid. Interestingly, we sometimes will use famotidine or one of the other H2 blockers in addition to a histamine 1 blocker like diphenhydramine or Benadryl, and folks who have rip-roaring anaphylactic reactions or allergic reactions sometimes we'll see the addition of an H2 blocker on top of an H1 blocker. And maybe seeing some benefit there. I'm not sure the data is really all that strong for its addition, but it's common in practice that these agents are pretty harmless for most patients and may offer some benefit, and so we'll see them sometimes used in that setting as well. H2 blockers like famotidine are available IV as well as PO. They cross the blood-brain barrier, so you worry about concerns for antimuscarinic properties like confusion, even causing a potential risk for delirium in some patients. And so we need to make sure that it's adjusted based on renal function. Most of the H2 blockers are renally eliminated, and so we need to adjust the dose if someone has renal insufficiency. So the most significant adverse effects associated with these agents are central nervous system effects, confusion, particularly folks who have renal impairment. And occasionally you'll see other things like thrombocytopenia has been noted occasionally with famotidine. If there's a time course to that, we want to keep an eye on that. The next group of agents are the antacids. And in the old days, before H2 blockers and proton pump inhibitors, really antacids were all we had. And they suppressed acid, they suppressed the acidity in the stomach lining by neutralizing pH. And there were really 4 modalities we commonly use. We'll use aluminum salts, calcium salts, magnesium salts, and the combination of aluminum and magnesium. You can use sodium bicarbonate. We don't because it is such a high sodium load. Most of the other products, the aluminum, calcium, and magnesium products are pretty low in sodium, at least the formulations that are available now. So let's first go through the differences between them. The aluminum hydroxide is only moderately effective at neutralizing stomach acid, so it's not all that effective. We rarely see aluminum hydroxide used alone. It also can cause constipation. Aluminum can accumulate in renal insufficiency. Many years ago, we used to use aluminum to bind phosphate in the gut for folks with renal failure. We'll talk more about phosphate binding in the gut, but we don't do that now because of aluminum accumulation in renal failure. So aluminum alone, rarely used. It does cause constipation. Not infrequently used is calcium carbonate. Calcium carbonate, or brand name of Tums, is pretty widely used in the community for patients. The advantage of Tums is that if somebody is calcium deficient already, then Tums, the addition of calcium carbonate, makes sense. Here's the downside. Two things. One is that it causes some constipation. That's usually not all as problematic as the aluminum salts are, as we noted above, but that's an issue. The bigger issue with calcium as an antacid is that we often see within a couple of hours after taking it that patients actually have an acid rebound. They actually have more acid secretion after a couple of hours. So we find many times patients who pop Tums for gastric upset or gastritis or stomach upset actually find themselves a couple hours later in a worse state and pop some more and need some more and continue to take more. So we still need to be aware of that. Probably one of the more common antacids used is magnesium hydroxide, and we can also use magnesium hydroxide to replace magnesium for patients. The issue with it is magnesium hydroxide, also known as milk of magnesia or MOM, will cause diarrhea. So it's pretty common that you will see folks have diarrhea with milk of mag. In fact, we use milk of magnesia or magnesium hydroxide as a laxative. The fourth issue we had listed here, fourth drug we have is sodium bicarb, and this is plain old baking soda. And if you pick up a box of baking soda, you will probably still see on the side of the box the dose to take as an antacid. We don't do that. We don't recommend that for patients. Particularly, it's contraindicated in patients who have either heart failure because of the sodium load or even hypertension. So we don't routinely do it. We will give sodium bicarbonate, not so much for its antacid properties, but we will do it for certain subsets of patients for whom bicarb replacement makes sense. Acid-base balance, particularly in some subsets of patients with renal failure, we'll see this sometimes used. Probably of all of the antacids, the most common ones you'll see used as an antacid is a combination of magnesium hydroxide and aluminum hydroxide together. And the reason they're combined is that hopefully the constipating nature of the aluminum hydroxide counterbalances the laxative properties associated with magnesium hydroxide. And these are available as probably the two most common formulations are either Maalox or Mylanta. And Maalox, M-A for magnesium, A-L for aluminum, O-X for hydroxide. So that's how the brand name Maalox came about. Pretty commonly, the things you want to worry about with aluminum or magnesium or the combination are folks in renal failure where you could get an accumulation of aluminum or magnesium. So we consider it a relative contraindication, not an absolute one, in folks with renal insufficiency. So basically what antacids basically would do will neutralize stomach acid. We can use them for peptic ulcer disease and GERD. Almost always, though, we will go with a proton pump inhibitor if it's a GI bleed, or perhaps an H2 blocker. And reserve antacid use just for symptomatic benefit, that if folks have gastritis associated with it, then these will be given as needed. But rarely do we use them really fully for therapeutic purposes like we did decades ago. The formulations, the acid neutralizing capacity of these agents vary. We talked about the adverse effects already. The other issue with antacids is you sometimes worry about how the antacid, if it's given at the same time as certain medications, may affect the absorption of that medication. And so we're going to be cautious about that. That's particularly true with either tetracyclines or with fluoroquinolone antibiotics, where the absorption of a fluoroquinolone or a tetracycline is going to be inhibited, sometimes dramatically, by the co-administration of one of these agents. Let's move on to sucralfate or carafate. This is an anti-ulcer medication that really doesn't have a lot of side effects. It's an aluminum binding salt that binds to an ulcer site, and as such, it provides a protective barrier or layer. It's used both acute and maintenance therapy for patients. It's not really much absorption of it. Almost all of it's eliminated in the feces. There is a little bit of absorption. It is an aluminum salt, so we are a little cautious about folks with renal failure and aluminum accumulation, but that's usually not a contraindication for its use. It will bind, however, to other drugs and so could cause some drug interaction. So the adverse effects with sucralfate, rare to get any. Some folks get a little constipation because of aluminum toxicity. The antacids given concurrently or a PPI given concurrently may affect the ability of sucralfate to bind to its ulcer site. And it's available as a tablet. It's a large tablet. They're hard to swallow for patients. They also have suspensions, or you can take the tablet and crush it or administer it as a slurry. There's other ways to sort of deliver it for patients who don't tolerate it taking the pill very well. One of the last drugs in this group we want to talk about is misoprostol or Cytotec. This is an analog of prostaglandin E1. It's its only indication anymore is to prevent ulcers for patients who are on long-term nonsteroidals. But what the big concern with this agent is that it actually can induce an abortion in a woman who's pregnant. So these are absolutely contraindicated in women of childbearing age unless we know that they are not pregnant and not planning to become pregnant. The other issues with this agent is it's really complicated to dose because it has to be dosed pretty frequently. Typically, the other adverse effects we see commonly is diarrhea or abdominal pain in a lot of patients, and that renders this drug really not all that effective. So we have to be careful about this drug in pregnancy in women of childbearing age. We have to dose it frequently. Typically, it's dosed with meals and bedtime. That's 4-time-a-day regimen. That's really hard for people to adhere to. You have to worry about pregnancy. You have to worry about a lot of GI upset, diarrhea, and abdominal pain. As such, you can see why this drug has really fallen out of favor. Okay, let's look now at the prokinetic agents. One of the agents here, probably really the only major prokinetic agent we commonly use, is metoclopramide or Reglan. And this agent is pretty much related to some of the antipsychotic drugs we'll talk about later on in the year. They suppress emesis by blocking receptors in the chemical trigger zone. They also will increase upper GI motility by enhancing acetylcholine function. So they're used for suppression of nausea, vomiting, and also for gastroparesis or severe gastroesophageal reflux. The problems associated with these agents, and we'll talk more about these a bit later, but in the context of them, if you remember what we talked about with the antipsychotic drugs, the chemicals related to that, these are dopamine blocking drugs. Metoclopramide, in a sense, has dopamine blocking activity as well. And so it's associated with sedation, sometimes diarrhea, and the classic extrapyramidal side effects of dopamine blockers as well, including akathisia, motor restlessness. We could see dystonic reactions, acute dystonic reactions, or Parkinsonian types of features. And long-term use actually poses a risk for tardive dyskinesia as well. And so metoclopramide typically is used very short-term in acute settings to manage someone with gastroparesis short-term or nausea vomiting short-term. And we are really careful about its long-term administration because of these side effects. It's available orally. It's also available as an injection. And so we'll see it sometimes used for purposes when we really have somebody with significant nausea, vomiting, or gastroparesis. One other prokinetic agent that we'll use, again, in a pretty limited fashion is erythromycin, the older macrolide antimicrobial. It is used for severe gastroparesis short-term, or sometimes if it looks like someone needs a little help in sort of GI motility, carefully used as well. at least in my practice, the only time I've ever seen anybody order erythromycin, either IV or otherwise, in this day and age for GI motility is done by a gastroenterologist. I have not seen really primary care folks want to sort of do that. Concerns with erythromycin are maybe allergies, abdominal cramping, nausea, vomiting, gut flora changes as an antibiotic, so you worry about maybe development of resistance. Hypersensitivity reactions happen. The other concern with erythromycin and all the macrolides is prolongation of QT, so you really want to be careful about that. Let's quickly review some of the issues we'll talk about in the discussion of disease management and upper GI. Stomatitis particularly is a condition we'll see in patients most often who have had certain types of chemotherapy. And so we'll cover that later in the year when we talk about supportive care in oncology patients. What we will spend some time talking here about is the management of gastroesophageal reflux disease, and in primary care that's quite common. We'll talk about peptic ulcer disease, just a bit about gastroparesis. We'll talk here about nausea vomiting, but we'll also cover nausea vomiting later on in oncology block as well. We'll talk a bit about pancreatic enzymes, and finally, very briefly, the role of drugs, which is really pretty minimal in the management of gallstones. So patients who have gastroesophageal reflux, which is really troublesome for symptoms and classically can cause concerns for Barrett's esophagitis or other concerns, more serious concerns. But typically, we're going to look at classifying GERDs in a couple of different ways. Typically, you can look at symptoms, whether they have classic or typical reflux syndromes, or sometimes it mimics chest pain. Many times, for example, folks who get admitted to the emergency department who come in for a rule-out chest pain, rule-out MI, will often be given a cocktail of antacids and lidocaine to have them swallow to differentiate, hey, is this chest pain they're experiencing, is it gastroesophageal reflux, or is it cardiac in nature or something else? We can also classify or consider the esophageal reflux as whether or not there's injury and where that injury happens. And so we're concerned about esophagitis and strictures, Barrett's esophagitis, or even the risk for certain types of cancers. And so we need to be kind of aware of that. And also the presentation can also be beyond just the classic substernal pain associated with gastritis or esophageal reflux. There could be a cough associated with laryngitis, types of reflux laryngitis that patients may have. They could have acid secretion that washes back up into their perioral area and lead to ultimately to dental erosions because of that acidity. And also, many times, particularly in pediatrics, it will present that looks like wheezing or asthma. And in fact, I've spoken to a number of pediatric pulmonologists over the years that often indicate that when they have a patient who presents with asthma, pediatric patient in particular, it can be seen in adults as well, one of the first things they're going to do is rule out whether or not they have gastroesophageal reflux, and that sometimes reflux and asthma will present in a surprisingly similar way. The symptoms typically are both localized heartburn, regurgitation, acid taste in the mouth. They might have cough and asthma-like symptoms. We alluded to a sore throat. They could have laryngitis or hoarseness. They could have erosion of the dental enamel. They could have chest pain or presentations that sort of go beyond the esophagus and even mimic bronchitis or otitis media, although those are much less common. What's really concerning or alarming is when folks have really painful swallowing, difficulty in swallowing, or have bleeding, significant weight loss, or significant chest pain, or there's any question of an epigastric mass. Things that will make reflux worse is gravity, anything that increases intra-abdominal pressure or lowers the lower esophageal sphincter tone. And so also direct mucosal damage can do that. So imagine if the sphincter tone in the lower esophagus is not strong, if it's weak, and that in combination with pressure in the abdomen, a tight belt, bending over, pressure somehow in the stomach, or in the area or below the diaphragm area. That pressure, that increases the pressure in the stomach with a lower esophageal sphincter more easy to open, imagine that's just going to push that gastric backwash up. And so those are really the kind of things we're going to look at doing to manage it non-drug-wise for GERD, is to elevate the head of the bed, for example, at night when people lay down, because they often have GERD at nighttime. We're going to look at avoiding drugs and foods and activities that will affect the tone of the lower esophageal sphincter. So we're going to avoid things like chocolate and coffee, caffeine, that can make that lower esophageal sphincter tone less tight. One of the classic things that actually makes lower esophageal sphincter tone worse are mints, peppermint in particular. And what that does is it actually renders that sphincter not to be as tight. And that actually worsens symptoms. Now, if you think about, if you go to a restaurant, they often, as you go by the cashier on the way out, they'll often have peppermints. And one of the classic reasons they do that is so that not only do you have a fresh breath perhaps in your mouth, but the other issue is that you will have a more pleasant dining experience for most cases, because if you have extensive stomach, your stomach is really full, if you lower the tone of the lower esophageal sphincter, what you end up with is able to expel gas and burp. And that's, for most patients, is a good thing, but if you have GERD, that's a bad thing. So you want to be avoiding mints or mint-related things as well. You also want to look at avoiding any pressure in the lower esophageal sphincter, so less tight-fitting clothing. Also encouraging patients to lose some weight. The added weight really renders GERD more problematic. So we're going to look at all those non-drug things to affect those aggravating factors. The long-term complications we are really worried about with long-term GERD are esophageal erosion, strictures or obstructions, Barrett's esophagitis, and it also certainly affects the patient's quality of life. So the diagnosis of GERD, typically we're going to look at whether or not their heartburn is responsive to acid suppression, particularly PPIs, and we want to look at this, if the difficulty is that the symptoms don't often predict the degree of esophagitis, and so you may need to get a referral with gastroenterology to do a more careful evaluation. You also want to rule out cardiac ischemia just as a part of your workup, just to make sure it's not cardiac in nature. Typically, the diagnosis is done officially by endoscopy, and if there's a question of a biopsy, we're going to get those a particular cancer, question of cancers, you're going to get a biopsy to sort of rule that out. And typically we're going to do endoscopy in patients over the age of 45 who present with symptoms, or if any patient is really refractory to initial treatment. We're going to look at pH testing, H. pylori testing as well on some occasions. Those really vary on how often that's done. The risk factors for GERD, women are at a higher risk for GERD than men. That's got often to do with estrogen levels or estrogen use, which make GERD worse. Men and women who are larger body weight and or obese, particularly if their body mass index is greater than 35, have a 3 to 6-fold higher risk for GERD than counterparts who are of normal body weight. And the combination of estrogen and severe obesity dramatically increases the risk for GERD. And so the issues we look at as part of our management strategy are to look at evaluating estrogen use in all women, particularly who come up with GERD, but also to address obesity as well. So the non-drug treatments, as we alluded to, which are usually only partially effective, but we need to do them anyway, is avoid those foods that affect the lower esophageal sphincter, caffeine. The other issue is smoking. Smoking is known to significantly lower esophageal sphincter tone, and so we're going to avoid that. We're also going to avoid mints. We're going to avoid irritants that the patient knows are problematic. Maybe reduce meal portion size and maybe fat intake, and avoid eating a couple hours before patient goes to bed, and to remain up right after meals, sometimes elevating the head of the bed as well. Weight loss, discontinuing nicotine, as we alluded to, head of the bed, avoid tight-fitting clothes, and avoiding meds that affect lower saturated sphincter if we can. Now, in addition, there are a number of meds that affect lower saturated sphincter tone. The alpha-adrenergic antagonists do, antimuscarinic drugs, benzos can do it, calcium channel blockers can do that, estrogen clearly does, nitroglycerin does, opioids do, anything antimuscarinic, particularly the tricyclic antidepressants do. The older pulmonary agent theophylline does, non-steroidals do, and aspirin does. So there might be a good reason to have these meds on board. Maybe you can't take them off for the patient, but we want to look at all of the etiologies here and avoid a problem when there is one. When we look at drug treatment, typically there's a couple of different approaches. You can start with a high dose and then go down, or you can start with a low dose and then go up. So those are kind of either step down treatments or step up treatments. The advantage of the step down, starting high and going low, is to get rapid symptom relief. But you could be associated with a little bit of overtreatment. But a lot of clinicians will do that. They just want to know, hey, is this GERD? Let's address this with a high dose PPI and then back off quickly. The other things that we can look at is while PPIs are more effective than H2 blockers, they also have maybe a different set of risks, which we alluded to as well. And so we kind of look at managing, maybe starting most patients with a PPI, but can we get good symptom relief with an H2 blocker, which some patients can. Many patients, however, will need a PPI longer term. So the guidelines from the American Gastroenterology Association for GERD look at a 8-week course of a PPI, and then just pick any PPI that is appropriate as long as the dose is appropriate, and then use maintenance PPIs if there's a return of symptoms. Long-term maintenance at the lowest effective dose or on-demand or intermittent is a general recommendation they recommend. You can use bedtime H2 blockers can be used in maybe either in place of or in combination too, but the data for long-term H2 blockers is probably somewhat limited. And the role of metoclopramide is somewhat limited and concerning for long-term effects. So they've also listed some of the dosing issues we see with these. Most of these agents given, PPIs in particular, given before a meal, and it can be usually done before breakfast or sometimes if the symptoms are more worse at night, perhaps before their evening meal. Let's now switch gears and talk about upper GI bleeding, a real concern for us in clinical practice. The etiology of upper GI bleeding varies, but in about half of cases or sometimes more, it's either secondary to nonsteroidal drug use, ibuprofen, naproxen, one of the other nonsteroidals, and or patients who have H. pylori. And we'll talk a little bit about H. pylori identification and management. We also see esophagitis or erosive diseases can happen for folks particularly with hepatic disease. We worry about esophageal varices. For patients who've had a lot of retching or vomiting, we worry about a Mallory-Weiss tear. Always with the GI bleed, we worry if the etiology is cancer. And for patients in critical care settings, we worry about stress ulcers. Classically, an upper GI bleed presents with coffee ground or emesis or hematemesis, but you can see other presentations as well, blood in all kinds of places. You'll see a lower blood in the stool, particularly if it's black and tarry, could be associated with an upper GI bleed as well. Nausea, vomiting, or melena, blood in the stool, shock, particularly folks who have a low pressure because of that blood loss is a concern when they get tachycardic and clammy and hypotensive. And you're worried about hyperperfusion with organ damage when it's a significant GI bleed and you've lost pressure, blood pressure, and a lot of blood. So we worry about the organs that are particularly sensitive in patients who have a low blood pressure and a loss of hemoglobin and hematocrit. including kidneys, liver, cardiac, and cerebral hyperperfusion. Always a concern with organ damage in each of those settings. We think about differentiating whether it's a duodenal ulcer or if it's a gastric ulcer. Duodenal ulcer a little farther down. Most commonly, duodenal ulcers are H. pylori or NSAID related. We could also have other etiologies or the causes, Zollinger-Ellison syndrome, which is commonly talked about but probably not all that commonly observed, cancers as well as certain infections. And they present, typically duodenal ulcers present with epigastric pain, which is often worse at night. It occurs 1 to 3 hours after a meal. It's often relieved by eating. It can also be an episodic pain. Gastric ulcers are also related to either H. pylori or NSAID use, but it could also be seen with Crohn's disease, which could affect any place in the GI tract or inflammation, or it could sometimes be a type of infection, particularly a viral infection like cytomegalovirus, although that's pretty rare. We also will present similarly with epigastric pain, but unlike duodenal ulcers, eating makes things worse, not better. So if a patient eats and they get relief, if it's a peptic ulcer disease, you think it's more duodenal in nature. If people eat and it gets worse, which secretes more acid, you think of gastric as its etiology. And particularly with gastric situations, we worry about cancers. So gastric, as opposed to duodenal ulcers, in the back of people's minds is a gastric cancer as an etiology. And we're trying to manage an upper GI bleed, particularly when it's non-variceal, meaning non-esophageal varices associated with portal hypertension in someone with liver failure. The first issue for us is volume resuscitation, particularly with saline. And we would use usually crystalloids like saline. We could consider colloids like albumin if it's very low. And typically, in addition to the volume resuscitation, you're probably going to look at blood as well. So if a hemoglobin is below 7, while you could say, hey, we might use albumin, more likely you're going to use a couple of units of blood at least. Our drug management, first of all, is get rid of anything that could cause it, like nonsteroidals. Then you're going to look at adding a PPI, typically as omeprazole, as a bolus dose of 80 milligrams, then a continuous infusion of 8 milligrams an hour for 72 hours while you're getting endoscopy set up. You're going to test for H. pylori, and if H. pylori is positive, you're going to treat it, and that can be done in lots of different ways. We'll talk about some of those tests in a couple minutes. And you want to assess whether or not the person needs secondary prevention with a PPI after the initial treatment is done. So H. pylori testing, H. pylori itself is known to be a carcinogen, but if you're going to test, then you've got to be willing to treat. And if you get somebody coming in for an endoscopy already, which is going to probably be pretty common in someone with a GI bleed anyway, if you've got a major one, then you want to get a histological evaluation usually. You could also get a rapid urea test, but the issue is there are a lot of false negatives, and you need to make sure that folks have not been on acid-suppressing therapy for the prior week. And so that's often not a realistic expectation for many of these patients. But the endoscopy and histological test is probably the thing you'll see most often. The non-invasive tests for H. pylori are also are commonly used. The serological test won't distinguish between active or past exposure, but might be a first option. The urea breath test, patients must have been off of antibiotics or anti-secretory agents for 2 weeks before they start. And the stool antigen tests, again, they have to be off of antibiotics or anti-secretory agents as well. And so that often limits the availability of using those tests. The regimens for H. pylori, if they're positive, typically involve a PPI plus an aggressive antibiotic therapy. And of all of the regimens that are used, what we want to do is to pick a regimen that has a high efficacy rate and is going to be tolerated by the patient. And typically what we'll look for getting is a regimen that is going to be highly effective and patients aren't going to have problems with. And so you can look down this roll and try to find one that is reasonable. And classically, what you'll see almost always used is a aggressive dose of a PPI plus amoxicillin plus clarithromycin or plus a metronidazole and a tetracycline or something like that. So you can look at all of these regimens. They have different efficacy. But the issue you've got to do is to make sure and say to the patient, hey, you really want to continue therapy for the full duration, because if we can cure H. pylori, we've dealt with your GI bleed risk. If you stop therapy early on, then you won't treat the H. pylori and it will come back. So if they've got a lot of GI upset associated with the macrolide or with the amoxicillin, you've got to kind of lead them through that and say, yeah, this is kind of a not comfortable regimen for a week or 2 weeks for you to take, but it's associated with a high degree of efficacy and you need to stick with it. And so you really got to encourage patients to be able to do that. The issues that we think about for morbidity and mortality with upper GI bleed, the risks associated with death are folks who have advanced age, who have blood in a gastric aspirate, if they've had repeated bleeding or other comorbid conditions, or if they're renal dysfunction, elevated serum creatinine, or they have sepsis or shock and hypotension. So these are really serious conditions. We look at a GI bleed, and those are sort of predictors of mortality. The clinical predictors of somebody who's going to have a persistent or recurrent GI bleed are some of the same groups of folks. Older folks are at risk for having that. Certainly if they're on a coagulopathy or anticoagulant therapy, that's a high risk, and we worry about stopping the anticoagulant. Initially, you have to weigh the risk and the benefit of anticoagulation versus not. And I think in most cases, for example, in AFib, we can stop it short term and the risk is somewhat quantified or minimal. Where we worry about this and where we sometimes have to continue the anticoagulant in addition to managing the H2 blocker, and it's one of the most difficult dilemmas we see in acute care, is if somebody has an active thrombus or if they have a mechanical valve. In those circumstances, we often have to anticoagulate the patient, and then your choice is typically going to be something that you could reverse quickly if the patient's bleeding doesn't get under control with aggressive PPI, fluid, and blood replacement. So it's a difficult scenario to look at. Some of the other things that are associated with recurrent bleeding based on endoscopy findings or if there's some other ongoing risk for their bleeding or sort of the symptoms or the predictors that are listed here. There are also things we think about with nonsteroidals and their risk for GI bleeding. And the patients who are at highest risk for GI bleeding with NSAIDs particularly are folks who've had already a history of a GI bleed. So if you've had a history of a GI bleed and you're on a nonsteroidal, you're asking for trouble. Also, just even patients over the age of 65 or who are on either high-dose nonsteroidals or are using the higher risk nonsteroidals, which are listed at the bottom of the page. These are folks who are also pretty high risk for GI bleed. And particularly the high risk agents we worry about most for GI bleeding are ketorolac, indomethacin, or piroxicam. Those three are sort of notorious for GI bleed risk. Probably the lowest risk is celecoxib, the COX-2 specific agent. Those risks of GI bleed are probably the very lowest. Lower risk would be maybe ibuprofen and diclofenac. But certainly ibuprofen and diclofenac higher risk than celecoxib. Preventing cardiovascular and GI risks with NSAIDs, typically if the reason we sort of say that is whether or not the patient with cardiovascular risk needs to be on aspirin. So if there's a low cardiovascular risk and a low GI risk, then use the lowest dose of a lower ulcerogenic agent. If they have a moderate risk, then you probably want to add a PPI or maybe misoprostol. High GI risk, a COX-2 inhibitor, and a PPI. If they have a cardiovascular risk where they require low-dose aspirin on top of it, then it's pretty similar. The nonsteroidal that's probably associated with the lowest risk for cardiovascular problems is naproxen. And so cardiovascular-wise, when you need nonsteroidal for somebody who has a cardiovascular risk, naproxen is probably the one that's considered safer for GI and particularly safer for cardiovascular risk. And so that's often the choice we'll go with. But typically because of that and because they added aspirin on board for these high-risk CV cardiovascular patients, we'll add a PPI typically as well. And very high risk, we want to avoid really all these agents as well. The stress-related mucosal disease that's seen in critically ill patients, these stress ulcers, are really cause some superficial but diffuse upper GI ulcers, particularly as is seen in ICU patients, particularly a patient on a ventilator. We see deeper mucosal ulceration leading to bleeding and hemodynamic response in these more severe stress ulcer cases. We also see hypoperfusion of the GI tract. We see altered susceptibility of the gastric acid that's there. We see an interference with the mucosal bicarb layer. It affects the prostaglandins, have some effect there as well. And so because of that, we recommend treating or prophylaxing for stress ulcers in folks who have high risks for them. Because the use of a PPI or an H2 blocker poses risks, and the risk for stress ulcer in folks who are not in the critical care unit is low, and because the risk of the agents are moderate, we typically don't use them except when there are risk factors. So the next slide will tell us what those risk factors are. We're concerned about folks on a mechanical ventilator for more than 48 hours, or folks who have coagulopathies or a low platelet count, if they've had a burn injury, if they've had head or spinal cord injury, if they've had a GI bleed risk in the last year, particularly if they've had trauma, if they've had major surgery, a longer surgery procedure, if they had lung injury, or in the right-hand column, 2 or more of the following: ICU stay greater than a week, sepsis, occult bleeding, high-dose corticosteroids, hepatic failure, acute renal failure. All these are kind of concerns. And so the prophylaxis in these patients, typically, the agent I think most folks will zero in on is probably, in this day and age, an H2 blocker as probably what I'm seeing people as first choice. And the reason for that is H2 blockers are reasonably effective at doing this, and they have a lower risk for C. diff compared to PPIs. And so PPIs could be used, but particularly in an ICU setting, you're always worried about comorbid conditions, including C. diff, colitis associated with antibiotics that we use widely in the ICU. And despite our best attempts at keeping C. diff spores at bay in any healthcare setting, it's really hard to be in healthcare and not have a patient be exposed to some C. diff at some point or another. So most often H2 blockers is probably the prophylactic agent you'll see used most often. Let's switch gears now to gastroparesis. This is going to be probably managed by either an endocrinologist or a gastroenterologist, but this is autonomic neuropathies associated with delayed gastric emptying, and sometimes comorbid with this is nausea and vomiting, typically in folks with diabetes. What we typically will look at as a non-drug regimen first is to look at more frequent but smaller meals, maybe processing the food in such a way so it's less likely to delay gastric emptying, and then maybe either metoclopramide or erythromycin. Both of these options, though, pose some risks. The metoclopramide, the long-term risk is for tardive dyskinesia and extrapyramidal side effects. Erythromycin, because of an antimicrobial and also other GI intolerabilities, not often a great long-term answer as well. But sometimes you have no alternative, and this is basically what we need to do. So you're going to do every non-drug thing before you start with the drug therapy. Let's talk a bit now about nausea, vomiting, how it presents, and how it's managed. Typically, the stimuli for nausea vomiting can be visceral via dopamine or serotonin. We could see gastric irritants, peritonitis, intestinal distension, could be pancreatitis or gastroparesis, radiation, very commonly chemotherapy, and we'll talk more about that later. Also, we could see the chemotherapy trigger zone influenced by dopamine and serotonin, histamine, muscarinic receptors, and substance P receptors. All are sensitive via these mechanisms to inducing vomiting. And so the agents that will affect the chemical trigger zone certainly include the chemotherapeutic agents, but also opioids can do this. Dopamine agonists, digoxin anesthetics, antibiotics can do it. Also can be triggered by metabolic things like diabetic ketoacidosis, hypercalcemia, hypoxia, uremia. Bacterial toxins can do that, and radiation can do it. Another trigger for nausea vomiting is vestibular, particularly folks who are sensitive to motion sickness or Meniere's disease or something like that, a labyrinth infection. And so in these cases, because it's affected by histamine and muscarinic receptors, we're going to look for vestibular therapies. We're going to use antihistamines or antimuscarinic drugs as our management for that type of nausea vomiting. And cerebral cortex, not well characterized, but noxious odors can also do that. But we'll also see the cerebral cortex clearly involved in nausea vomiting associated with stress, particularly post-traumatic stress. And I think we've all, known individuals and maybe have had that experience ourselves, that in a very, very stressful, traumatic situation, sometimes people just start vomiting. And so that's probably mediated via the chemical, the cerebral cortex. There are a number of conditions we think of in nausea vomiting and sort of overlap some of the things we said. Certainly infections, we see some of it. Gastrointestinal, we talked about. Central nervous system. We also see it in addition to concerns for psychological stress or post-traumatic stress. We also see migraine headaches have commonly associated with them nausea vomiting. Stroke, some seizures do. Motion sickness certainly does. Even meningitis can. Endocrinology, we'll see early pregnancy or first trimestral pregnancy particularly associated with a high risk of that. Uremia, DKA, hyperkalemia. Cardiovascular, sometimes folks with an MI will present with nausea and vomiting as part of their pattern for an MI. Occasionally also seen with heart failure as well. And the consequences of uncontrolled nausea vomiting is certainly dehydration, electrolyte disturbance, and that's true for almost everybody. You're also worried about aspiration, particularly nausea vomiting, for example, associated with alcohol withdrawal. Or associated with anybody who's got is cerebrally impaired by some way, where their aspiration risk is high. And finally, excessive retching can increase the risk for Mallory-Weiss tear. So we're going to be sort of careful about all of those concerns. There are a number of different antiemetics that we can choose. Let's look at some of them as categories. We'll come back and talk about these again when we talk about the oncology block, but the phenothiazine agents, the two phenothiazines, these are chemically related to the antipsychotics, these dopamine blocking drugs, promethazine and prochlorperazine or compazine. They're associated with a lot of extrapyramidal side effects and QT prolongation. The serotonergic agents, the most common one we'll see used is ondansetron. There are some others as well that are still used, but the other three are primarily only used in oncology. Ondansetron used pretty much everywhere, and we worry at least in higher doses for prolongation of QT. The antihistamines, we can use these for other types of nausea vomiting. These are more commonly used for motion sickness or vestibular issues. They're not as commonly used for other types of nausea vomiting, and they are sedating and antimuscarinic. The butyrophenones, or the antipsychotics, are Haldol and droperidol, are sister drugs, and they're quite effective for nausea vomiting. They do, however, cause both QT prolongation and extrapyramidal side effects because of the dopamine blocking effect, so we want to be careful of that. And the NK1 antagonists, are primarily used in oncology. We'll talk a bit more about those in the in our discussion of oncology nausea vomiting therapies. Some of the last things that you'll sometimes see used for antiemetics, one is scopolamine, the antimuscarinic, and that's almost always just used for vestibular or motion sickness. We sometimes will see it used in palliative care. In that case, though, it's more often used for drying secretions than it is for use for nausea and vomiting. Dronabinol or marijuana and medical marijuana has some benefit in folks who have particularly chemotherapy-induced nausea vomiting and can improve appetite in some folks, and so that has a role. And then the emetrol, the oral solution or phosphorylated carbohydrate solution is probably considered a safer choice in early pregnancy. In the old days, what we would see is people would use Coca-Cola syrup, and pretty much that's what we're looking at here. And then finally, doxalamine or combinations of doxalamine for women who don't respond to more conservative management. What's not listed here, but probably works reasonably well too, is the use of ginger or ginger ale and salt crackers. And so certainly women who have had early morning, first trimester nausea vomiting, it's pretty common that ginger ale or ginger and enhancements in combination maybe with crackers is something that's often used as a sort of a first-line agent or appropriate therapy before we go to some drug therapy. Let's now talk a little bit about the pancreatic enzymes, which reflect the exocrine function of the pancreas. The four enzymes we typically think of with pancreatic enzymes are lipase, amylase, chymotrypsin, and trypsin. And deficiencies of these, which are seen particularly in patients with cystic fibrosis, sometimes also with patients with some degree of pancreatitis, will cause, among other things, interruptions in digestion, particularly interruption in the digestion of fats. There are a couple of different formulations that are available, and we'll look at replacing these, particularly in folks with cystic fibrosis, but also in other individuals who might have deficiency of pancreatic enzymes. They will typically see patients who are on these therapies. We need to dose them with meals. What we're trying to do is mimic the exocrine secretion of pancreatic enzymes, which would be elevated associated with a meal. Here's a list of some of the pancreatic enzyme replacement products that are in the market. And you'll see there are different brands. These are recently reformulated in the last 4 or 5 years from earlier formulations. And they typically have primarily lipase and amylase with some protease in them as well. And each of these formulations vary a bit in which products are available, vary in the formulation of which enzymes are in the products and how much of each. Typically what we find is that when a patient is on one of these products, we try to reasonably mimic the same dose that they've gotten, or the same brand ideally, but sometimes that's not possible, but mimic the same combination of lipase, amylase, and protease that they've responded to. And typically patients will titrate their dose according to, among other things, stool fat or some other marker of how effective these are. Let's now look at giving drugs associated with pancreatitis. There are a number of them that can cause pancreatitis. Probably, though, in practice, the greatest two etiologies of pancreatitis that we see for inpatients with severe pancreatitis are either alcohol, or the other issue we'll see with patients with pancreatitis is very elevated triglyceride levels. And so if we've ruled out both of those issues, then we start to look at which drugs cause pancreatitis or could be causing pancreatitis. And the list here is some common agents we'll see. Probably of all of them, the two that I would zero in on are estrogens, and we sometimes see this, for example, for a woman who may start hormonal contraception, or valproic acid. Valproic acid has a moderately high level of pancreatitis associated with it. There are a few different ways we classify pancreatitis by severity, but typically we look at whether it's mild, moderate, or severe. And in severe pancreatitis in particular, we're looking at, even moderate, we're looking at inpatient management. And typically what you'll see is here's the criteria, for example, in the right two columns at admission that are associated with in risks for severe sequelae associated with it. If we see folks who on admission are older patients, particularly who have an elevated white count, elevated glucose or serum lactate or AST levels, those are kind of markers for more severe, complicated issues. And then other issues that are going to be problematic within the next 48 hours are if their hematocrit drops, if their third spacing fluids, if their oxygenation is reduced, or if their renal function, or particularly the BUN, becomes elevated. All right, as we look at gallstones, cholelithiasis, the first issue to think of is, do we have any drugs on board that contribute to gallstones? And there's really two drugs that we think of that are causes of gallstones. Probably the biggest one we think of are the estrogens. And so particularly gallstones are problematic for women who start hormonal contraception. Gallstones are also likely more problematic in women, more problematic in folks who are obese, more problematic in high levels of estrogen as well. And then also gallstones are probably likely over the age of 40. So all of those are variables we think of. So if we have a patient with new gallstones, look back at their drug therapy, among other things. Is it a woman who's just started estrogen therapy? That might be a reason to reconsider the estrogen use. The other drug that can be associated with gallstones, or at least biliary sludging and perhaps the risk of gallstones, is the cephalosporin antibiotic ceftriaxone. To the extent that that really causes severe gallstones, probably not, is probably rare, but the biliary sludging is an issue we think of for folks who are on ceftriaxone if they have already a pre-existing gallstone problem. As far as our management goes for gallstones, the drug therapies really are not all that effective. Chenodiol or ursodiol are probably the two agents that have historically been used, but they don't really work all that well. So most clinicians, gastroenterologists, really don't go there. We look at either cholelithiasis or a surgical intervention for managing gallstones. And then sort of long-term management is looking at a diet as well. When a drug is considered, chenodiol is probably the one we'll see used most often when it's used, and it will reduce hepatic production of cholesterol a bit. It doesn't work for many types of stones, particularly those that are radiopaque. Its success is typically only seen in some patients, a subset of patients, and it's most likely in women with low cholesterol and who have small stones and are able to tolerate the drug. And therapy is prolonged for 2 years. And so because it also associated with diarrhea in almost a third to a half of patients and can cause liver injury and is contraindicated in pregnancy, this is an agent that is really not used all that often. All right, we're going to spend most of the rest of this block talking about hepatic disease. And here there's a lot going on, and yet, and in practice, I think you'll see this fairly frequently, lots of things to consider with patients with hepatic disease and drug therapy that we target for specific areas of folks who have mid to late stage liver disease. So one of the things we think of with hepatic disease is scoring the severity of hepatic disease. And the Child-Pugh classification system for severe cirrhosis is one that's been used for many years. In addition, the one that's been used quite often in the last decade or so is the model for end-stage liver disease, or the MELD. And so we're going to look at those to help assess how severe someone's hepatic disease or how progressed it is. We'll also look, when it gets severe, whether or not they have ascites, whether they have hepatic encephalopathy, whether they have portal hypertension, whether they have the gastroesophageal varices, whether they have risk for spontaneous bacterial peritonitis, and whether or not that's related to alcohol, other drugs, or something else. And so all of these are things we think about as a clinician as we're trying to look at what therapies we use for primary or secondary prophylaxis to reduce their ongoing risk or to manage each of these subsets or presentations of hepatic disease. So the child-proof classification of severe cirrhosis, typically we give a point scoring system based on the degree to which there are markers for severity of cirrhosis. Encephalopathy, whether it's there or not, ascites, whether it's there or not, elevated bilirubins and reduced albumin levels. And finally, we look at the INR, the prothrombin time above normal. And so in practice, you will see that many patients who come in the hospital with liver disease, one of the things, two or three things we're going to look at for lab monitoring is their bilirubin, their albumin, and we're going to look at their INR, their prothrombin time, and the degree to which they can no longer make clotting factors, the degree to which they can no longer make albumin, or the degree to which they produce more bilirubin. Those are all correlated with the severity of their liver injury. In many cases, you might ask, okay, well, why aren't we using AST and ALT as liver enzymes, as markers of severity of liver disease? And the reason is that you will see in early liver injury, those markers go up, those enzymes go up dramatically. But if you have advanced liver disease, you may not actually have enough functioning hepatocytes to actually produce those markers. And so as such, they're not good, reliable indicators for mid to late stage liver disease. And so again, bilirubin, low albumin, or a low number of clotting factors represented by a high prothrombin time or INR are better indicators of liver severity, liver failure severity. The MELD stage also looks at other sort of variables listed here, and many times these are, in a sense, automated by a calculator or some other sort of way to do that. Sometimes hospital information systems may incorporate these variables in that calculation or that score. So you'd look at that, but they are looking at some of the same variables, particularly INR and bilirubin. They'll also look at renal function or creatinine as an indicator of that as well. So let's first look at ascites, and we're going to talk about the prevention and treatment of ascites, but first let's think about what ascites is. It's a free fluid accumulation in the abdominal cavity, and it's really a function of two things. It's a function of the portal hypertension, how much pressure in the portal vasculature is there that actually will drive fluid from the portal vein and the portal architecture of vessels into the abdominal cavity, causing ascites. And secondly, how little albumin is there to keep that fluid instead of in the portal circulation to, where you want it, the albumin. The more albumin there is, the more oncotic pressure is going to keep it in the vessel. So if there's not a lot of albumin and there is a higher pressure in the portal circulation, you're going to see more ascites. And so our management strategies are going to look at ways that we maybe could increase albumin to increase oncotic pressure in the vasculature. Long term, also maybe to look at reducing portal hypertension with maybe a beta blocker, sometimes adding a nitrate to that. We'll also look at diuretics, and furosemide could work, but more commonly we'll look at spironolactone. And the reason we're going to do that is that in portal hypertension and ascites, the central vasculature appears dry while all this fluid's in the abdominal cavity, And that triggers the adrenal gland to release more aldosterone, which only makes the matters worse. And so that extra salt and water accumulation and increases portal hypertension. You get this vicious circle. And so aldosterone is a mediator of ascites, and spironolactone as an aldosterone antagonist really makes a lot of sense. So commonly you'll see in ascites, we're going to give spironolactone. We might start at 25 or 50 milligrams a day, but we're going to aggressively manage that as well, as long as a patient's perfusion is fine, their renal function remains stable, their potassium is okay and not elevated. We're going to increase the spironolactone all the way up to 100 milligrams 4 times a day if need be. And typically, if there's fluid overload, we're going to add furosemide to that as well. So it's pretty common to use furosemide and spironolactone together in the management of ascites. What we have to watch for is the condition known as hepatorenal syndrome, which can happen even in the absence of spironolactone and furosemide, but may be accentuated by its use. In that, with hepatorenal syndrome, we see a lot of fluid in the ascites, but we have the central volume dry because of the low albumin and driving fluid across into the abdominal cavity. And so we have to watch renal perfusion and watch renal function carefully and titrate our dose of the spironolactone and furosemide, in part related to the patient's response, but also their renal function stability. We can also do paracentesis. That's commonly done, particularly if there's tense ascites, but we need to be careful about how much fluid is drawn off. And I'll refer you to your medical team in GI discussion of that and the role of paracentesis. The advantage is you draw a lot of fluid directly off the abdominal cavity, but the problem is if you do that too aggressively, you increase the risk for hepatorenal syndrome because you still will have perfusion of fluid from the central vasculature out to the abdominal cavity, and it will make renal perfusion even worse. So you need to be careful about that. We can use or consider using IV albumin, and that will keep more fluid in the vessel. And ideally, this seems like a great idea. The problem, though, with albumin is A, it's a blood product. B, the benefit you'll see from giving IV albumin is going to be limited to a day or two. You're not going to really see a long-term benefit with IV albumin. It's a blood product, and so it poses a risk for all the things that blood products can cause, including increased hypersensitivity reactions. Usually when I see in clinical practice folks reach for IV albumin in a patient with ascites, it's a patient who typically is centrally very dry, and has significant ascites and is presenting with hepatorenal syndrome. That's typically what we'll see it used for. But it's as a long-term or a regular management of ascites, it really does not make sense. As we alluded to, we're going to monitor electrolyte balance, particularly potassium with spironolactone and furosemide decreasing serum potassium, spironolactone increasing it. We're going to look at renal impairment, particularly hepatorenal syndrome. And with spironolactone, you could also see gynecomastia, which is not an unusual situation to see with spironolactone therapy. Next, let's look at hepatic encephalopathy. And this is the accumulation primarily of ammonia in a patient with end-stage liver disease. And that ammonia accumulation leads to really changes in mental status and cerebral status. And so we're going to do a lot of things here to try to reduce the nitrogen load in the gut. One common therapy that's been used for many decades now is lactulose, non-absorbable disaccharide. It's metabolized by colonic bacteria to acetic acid and lactic acid, and that results in ammonia trapping, particularly the ionized form of ammonia trapped in the colon and excreted. And what we're going to shoot for is to give a dose of lactulose 3 or 4 times a day until the patient has 2 or 3 loose bowel movements a day and has an improvement in cognition. So that's a consideration for use, and that's really, many clinicians still consider lactulose as the first-line therapy for hepatic encephalopathy. Over the last decade, there's been sort of conflicting evidence about how truly effective lactulose is. You'll find some data that say it works pretty well. You find a lot of clinicians who say they see a response to patients on it. but you'll see other data that suggests maybe it's not as effective as we once thought it was. We could also look at antimicrobial therapy. The two older agents we'll see sometimes used is neomycin, which is not absorbed orally, and that is that's given orally to trap or affect colonic bacteria to affect ammonia production. Metronidazole is a possibility. The problem with metronidazole is it's also in severe liver injury is considered contraindicated or needs to be dose adjusted. And so many clinicians don't use it because if you've got hepatic encephalopathy, by default you have liver injury. The third issue that is used pretty commonly is rifaximin. And rifaximin is probably better tolerated in a lot of patients than lactulose. Certainly doesn't cause the diarrhea that you see with lactulose. Probably at least as effective. And the dosage here for rifaximin in hepatic encephalopathy is 550 milligrams twice a day. The other things that you will sometimes see used, or it's more anecdotal, is the benzodiazepine antagonist flumazenil. Flumazenil is an agent which will we use it for benzodiazepine overdose, and because of the nature of the benzodiazepine-like substances associated with hepatic encephalopathy, it can improve mental cognition in a patient with hepatic encephalopathy, very short term for a couple of hours. Clinically, I've only seen people use flumazenil a couple of times in hepatic encephalopathy, and usually that was a situation where it was a one-time issue where families, the person who was hepatic encephalopathy was far along in their disease state, and there were clinical issues or ethical issues as far as informed consent or talking with patients or something about what the needs of the patient were short term to allow enough cognition for the patient to improve symptomatically for an hour or two while flumazenil was taking the hold. But it's not a long-term answer or resolution. There's also some question about whether zinc plays a role in folks with hepatic encephalopathy. To the degree that it does, it's a bit debatable, but it probably wouldn't do any harm to add zinc to a patient with hepatic encephalopathy. So the way that we sort of look at or consider stratifying hepatic encephalopathy is based on how severe or what their grading is for their symptoms, and it's sort of listed here as you can sort of see that. The difficulty is that for folks who are taking enteral lactulose, you need someone who's cognitive enough to swallow and take that lactulose. And once you get encephalopathic, then you can't give the lactulose unless they have NG tube in place or something like that. Or you could give the lactulose as a rectal retention enema, and we do that. We do lactulose, but it's a huge volume. It's got to be uncomfortable for patients for ammonia trapping it, and really the ideal circumstance is really to address hepatic encephalopathy aggressively before the patient loses consciousness and their ability to swallow. There are other sort of things to think about in folks who have type C cirrhosis, and it's sort of listed here. Lactulose considered first-line therapy, rifaximin as add-on to lactulose. And we see this pretty commonly in practice. Are the two most common modalities are going to be lactulose and really maximizing the lactulose dose, and then adding rifaximin to that. All right, let's move on to gastroesophageal variceal bleeds or risks. And here we're really concerned about someone with the combination of portal hypertension and friable vessels around the esophagus, the gastroesophageal variceal, and the risk for bleeding. And so because of that, we really are looking at aggressive management here. And for someone who has acute esophageal variceal bleeding, we're going to look at fluid resuscitation. We're going to look at endoscopy, and sclerotherapy is going to be done emergently by the GI surgical team, often with variceal banding ligation banding. In addition to that, we will often use octreotide or somatostatin to reduce portal pressure aggressively. And typically, octreotide is what we'll see used most often for a 3 to 5 day continuous infusion after a bolus. Some settings use somatostatin in place of octreotide. Alternately, instead of octreotide, vasopressin is a possibility. And we'll also look at during the interventional procedure for sclerotherapy or banding, you often will see prophylaxis used, often ceftriaxone as the agent I think we typically most often see used. If therapy for all of these is unresponsive, there's a possibility of a Blakemore tube of balloon compression, but it is a really invasive and uncomfortable type of procedure, so that's not sort of commonly used. And you could also look at a transjugular intrahepatic portal shunt, which is a surgical procedure that really most clinicians really try to look at getting management with the initial approaches for sclerotherapy, banding, and octreotide therapy, and being aggressive with those. For folks who are at risk for esophageal varices, we're going to look at considering a beta blocker for them, and particularly if they have small varices, they're going to be a candidate, but have a Child-Pugh score of B or C, or they have larger varices. We're going to use the most common beta blocker is nadolol. We typically want one that has blockade of beta 2 as well as beta 1 receptors. And nadolol is probably the one that's been studied the most often. We're going to titrate them to a dose of nadolol for a heart rate of between 55 and 60 beats per minute, or at least a reduction from their baseline by 25%. So nadolol is probably the agent you'll see used. Sometimes they'll add nitrates to that, which also might be effective with a beta blocker. But the difficulty is that most clinicians will instead go with a higher dose of nadolol where there's good data rather than a lower dose of nadolol and adding a nitrate on board, because by adding nitrates you limit how high you can go with the nadolol. For folks who've had a history of variceal bleed, these folks really almost absolutely need beta blocker therapy to prevent a second bleed. And so we're going to use, again, using a non-selective beta blocker and maybe looking at adding a nitrate to those patients and really being pretty aggressive about that. Another issue with liver failure is the risk for spontaneous bacterial peritonitis. These are infections of a previously sterile acidic fluid. It can be present in up to 30% of patients who are hospitalized with cirrhosis and ascites, and it's associated with a pretty high rate of in-hospital mortality. And it can be spontaneous with a seeding from acidic fluid that's not really, you don't have a clear, otherwise a clear etiology. Typically you worry about gram-negative bacilli more commonly than gram-positive, and E. coli, Klebsiella are probably the most common pathogens you'll see, but you'll see other gram-positive, including strep and even Staph aureus as possible, possibly indicated. So the treatment of spontaneous bacterial peritonitis, because it has a high mortality, is we're going to be aggressive, and the therapies we'll see most often used is cefotaxime or ceftriaxone, and pretty aggressive doses, 2 grams a day for ceftriaxone or 2 grams every 8 hours for cefotaxime. You could use a quinolone. We're typically going to do 5 or 10 days of therapy. And many times we'll add albumin here, particularly if there's a risk for hepatorenal syndrome. So if their renal function is falling off and you're worried about hepatorenal syndrome in combination with their ascites and their bacterial peritonitis, then albumin makes sense for, again, a short window of time. In preventing for patients, we'll look at either quinolones, Bactrim, or ceftriaxone as prevention in folks who are really considered high risk for SBP, and that would include folks with a concurrent variceal bleed. Most of the remaining slides here, we're going to talk about hepatitis, and there's already been, in a sense, we've reviewed some of this content already in infectious disease block, but let's sort of go through the hepatitis and our management here. First of all, hepatitis A, consider a fecal oral transmission. It's usually self-limiting, and you will see either pre-exposure prophylaxis or post-exposure prophylaxis. Pre-exposure prophylaxis, particularly folks who are going to an area endemic with hepatitis A, is vaccination, is the most common situation for Hep A vaccine. And the criteria for who are candidates here really are folks who are going to an area where either Hep A is endemic or they have risk factors for fecal oral transmission of hepatitis A. And then we'll look at the hepatitis A immune globulin is going to be used occasionally prophylactically when you haven't had enough time for the vaccine to sort of kick into gear. But more commonly, we're going to use the immune globulin post-exposure. And we'll occasionally see this in the United States. Usually this is in a situation where either there's been a foodborne risk exposure, usually like in a restaurant or a food setting for Hep A, or in a situation where there is a concern post-disaster like a hurricane or flood situation where septic systems are implicated. So post-hurricane or something, it's a risk for Hep A exposure. And in those cases, you can also look at patients getting vaccinated as well for post-exposure prophylaxis. All right, let's look at treatments for hepatitis B. And we've seen some advance in the management of Hep B over the last 4 or 5 years. So let's go through some of the national guidelines from the American Association for the Study of Liver Disease, and they put out some treatment recommendations for management of chronic Hep B. The approved treatments, and as a sort of a list of a table here, are using in what was an older regimen that is still a preferred regimen in some patients, is using pegylated interferon product. And this interferon basically works, augmenting natural cytokine activity as its antiviral mechanism. And generally fairly well tolerated in most patients. The big issue with the interferons is that they are considered contraindicated in patients with severe major depression or suicidal ideation, so we have to watch for that. We also have entecavir, which is guanosine nucleoside analog, which inhibits Hep B synthesis. And that's also a pretty standard therapy to use in active Hep B. And then we have 2 different formulations of tenofovir. Tenofovir are antiretroviral agents. They're nucleoside analog reverse transcriptase inhibitors, which are also used in Hep B and HIV. And these agents have a certain role also in Hep B. So we'll come back and talk about tenofovir a bit more when we talk about HIV. But they're generally well-tolerated agents. The next slide will go through a little more characterization of what we expect for each of these agents. So the pegylated interferon, interferon alpha 2A, really binds to the human type 1 interferon receptor. The big issues with this, it's a sub-Q injection once a week. It's long-acting because it's pegylated. It's given for almost a year. And its major concern we worry about, and I think the biggest issue whenever you hear interferon therapy, is the risk for suicidal ideation and depression, severe depression. So folks who have a history of depression, a history of post-traumatic stress of any kind, or have any potential for suicidal ideation, we would not use an interferon product for them. And for everyone else who's on interferon, we need to monitor for that should that come about. Entecavir, also an agent, could be used for Hep B, also considered a first-line agent, as are the 2 different formulations of tenofovir, which could be used as well. There are also some non-preferred second-line agents in Hep B, and we're not going to go into depth here. Lamivudine, adofovir, and terbinafine are agents which, because they're not really first-line, I don't think it's critical for us to go into depth with them. But I'd encourage you that if your patient is on one of these therapies, become familiar with both the adverse effect profile of these agents, particularly the risk for lactic acidosis or pancreatitis or acute kidney injury, and that really it's those adverse effects that and their efficacy that has probably rendered these agents more second line. The American Association for the Study of Liver Diseases also outlined their efficacy for their first-line agents, and they're relatively effective at viral suppression, and the charts sort of list here, depending on what the hepatitis B status of that individual patient is, so you have at least familiarity with that. And finally, the next two slides for Hep B look at our management strategies for someone who is surface antigen positive, and what we then look at based on whether their liver function tests are within the upper range of normal or 2 times or more than 2 times above the upper range of normal. Also looking at their hepatitis B viral DNA load and assessing when we treat and when we don't treat. So you can look at this sort of graphic, which helps the hepatologist, who's really going to be the person managing Hep B, to sort of look at least what the latest recommendations and guidelines are on what we do or how we monitor or treat a patient with hepatitis B. And for a hepatitis B surface antigen positive versus who then converts to negative status, also the recommendations for treatment guidelines, also based on LFTs. Couple of the last couple of charts or tables here, and the last one from the American Association for the Study of Liver Diseases is the antiviral options in the management of antiviral resistance. So if you see resistance, then what are the roles for those second-line agents when the first-line agent hasn't worked, or vice versa? And so there's some guidelines here that the hepatologist who's involved in managing Hep B or the infectious disease service sort of may look to for guidance as far as how to manage that. A couple of tables also that may be helpful as a review of the hepatitis B serologies, the surface antigen status, core antigen status, and E antigen status, and then whether there are anti-surface antigen antibodies available, or anti-core antibodies, or anti-E antibodies. So all of these are sort of markers that help assess the status of the person who has hepatitis B. There are also sort of definitions of whether someone is in an inactive carrier state for hepatitis B versus if they've got chronic hepatitis B infection. And that's got to do with both serological markers, but also whether or not their liver function tests, particularly their AST or ALT, are elevated either intermittently or persistently. Finally, and probably one of the key issues that every primary care provider should be aware of, is the hepatitis B vaccination schedules, which is most of hepatitis B is preventable with appropriate vaccination. And in fact, with newborns in the United States, it's routine really within the first hour of life to start their hepatitis B vaccine. And Hep B vaccine is actually the first vaccine any infant would ever get. And they often get it before they leave the hospital if it's a hospital-based birth. So there are sort of guidelines. There are different products that are used. Some products are intended for infants or children, others for adults. You want to make sure you have the correct product correlated to what the indication is for. And then if you have or should have available to you on your mobile device, for example, the CDC's has a vaccine app that is superb, and it will help guide you through all of the vaccines based on age and comorbid status, which patients are candidates for which vaccines, and gives you most of the basic information you need about each of those vaccines. So I really encourage you to do that. But virtually every patient who's at risk for hepatitis B, certainly those include anyone who works in healthcare and anyone else who works in a setting where Hep B is more problematic, as well as folks who have certain risk factor behaviors for hepatitis B. And in general, most patients are going to be candidates for a Hep B vaccine one way or another. The Center for Disease Control also posts and updates periodically post-exposure guidelines for folks who have not had hepatitis B vaccine but have had an exposure. That exposure could be, a bite or a blood-borne transmission of something like that for hepatitis B, or another transmission for hepatitis B. And so you want to look at what the role of pre-exposure testing is, and then who is a candidate for post-exposure prophylaxis. Typically, the most patients, what you'll see is that you will look at both the patient being vaccinated if they haven't been vaccinated or complete vaccinated status, and also give hepatitis B immune globulin. And Hep B immune globulin is sort of a standard approach when you can quantify what the hepatitis B exposure risk might have been. Let's now move on to hepatitis C. And I think one of the things that is really great news in infectious disease over the last 5 years or so is the availability of really very effective treatments for Hep C, which has really revolutionized the management of hepatitis C. So there are different treatment modalities that are effective for hepatitis C viral infections. There are NS5A inhibitors, the non-nuclear and nucleotide NS5B inhibitors, and the protease inhibitors for the NS3. So they work in different points in the cycle of viral replication. And typically what you'll find is that the regimens that are used, typically in combination, usually will hit 2 different points so that there is less chance for resistance. If there's a potential for resistance for a Hep C viral particle with one of the agents, the other agent will sort of hopefully prevent replication. And the recommendations and the guidelines are often changing, but here is a table that lists the hepatitis C medications that are on the market. The 2 in the lower right-hand corner are actually agents that have been discontinued. But the 4 agents that are highlighted here, and we'll go through them in more depth and we'll look at where they show up in the guidelines. The ones that are highlighted in the red box here are the 4 combination therapies that are the most common first-line therapies for most of the genotypes. And so that's where our focus really is going to be for this sort of this block. In practice, if you're managing Hep C, working usually with a hepatologist, you're going to be much more familiar with all of these agents. But you will see a fair number of patients on a regimen for one of these, and you need to be aware of things to think about when a patient's on one of these combination products. So one of the 4 is Zapatier, which is a combination of an NS5A inhibitor and an NS3 for a protease inhibitor. So really by using sort of 2 different mechanisms again, this combination is pretty well tolerated in fact, all of the 4 first-line agents are pretty well tolerated for most patients. The common side effects are usually headache, nausea, and fatigue. Another combination sort of product here with another protease inhibitor in combination with an NS5/4 is Mavriet, and that is also sort of widely used or pretty widely used or available as part of one of the protocols as well. The third one, probably the one that has most name recognition for clinicians, is Harvoni. And this is a NS5A and a 5B inhibitor, also pretty well tolerated, weakness, nausea, headache, fatigue being the major ones. And finally, Epclusa is a NS5A and B inhibitor combination as well, also pretty well tolerated. And so you'll see these regimens there. The nice thing about these agents, these combination therapies, is that they're fairly easy for patients because most of them require only a single daily dose, and it's all depend on the genotype and whether the patient has been treatment naive or not. So we'll go through some of the national guidelines regarding which agents are chosen and which, and how clinicians pick which one. So with hepatitis C, typically what we're going to find is that we're going to look at the genotype, and then we're going to evaluate, depending on the genotype subtype, whether or not the patient is treatment naive or has had treatment and failed treatment of one way or shape or form, and whether or not they have cirrhosis existing or not. And so we're going to really focus on the particular first line as opposed to the alternative regimens. And those include the 4 regimens that we just really spoke about. But the type of drugs that we'll look at typically are regimens that are a daily fixed dose regimen of a single product, and the duration could be, depending on the particular regimen that's chosen, anywhere from 8 to 12 weeks. The data, generally good for these regimens, well tolerated, and the only downside to these hepatitis C regimens, particularly in the United States, is that they are extraordinarily expensive. And when they first came out, a course of therapy for 8 to 12 weeks was in the range of about $80,000. That pricing has come down. There's been a lot of concern among clinicians and patient advocates regarding the availability of affordable hepatitis C regimens, so that is in the process of being evolved, and hopefully we'll see more affordable hepatitis C regimens and insurance coverage to be widespread for it, but this can be a speed bump for a subset of patients. There's also similar regimens available, but often they're longer regimens for folks who have compensated cirrhosis, who are genotype type 1A. In these cases, all the regimens are 12-week regimens. Here are the national recommendations for the choices, either 8 or 12-week regimens for genotype 1B without cirrhosis, and there are a couple of 8-week regimens listed here. And then 1B with compensated cirrhosis, all of these patients require the full 12 weeks of therapy, and one of the approved regimens that's listed here. Here's the recommendations nationally as of early 2019 for the genotype type 2 without cirrhosis. There's really only 2 choices here, one of them being an 8-week regimen. Here is genotype recommendations for genotype 2 with compensated cirrhosis, and these are both 12-week regimens. But you can see by the genotype, the theme is that the genotype dictates which regimens have more efficacy in studies, so which ones are first-line therapy. And then you'll see that some of the shorter regimens are possible if a patient doesn't have cirrhosis, but usually for patients who have cirrhosis, they require a longer duration of therapy. For genotype type 3, there's an 8 or a 12-week regimen without cirrhosis. For genotype type 3, our regimens are longer duration because of the compensated cirrhosis. For genotype type 4, again, some 8 and 12-week regimens. And for genotype type 4 patients with compensated cirrhosis, all 12-week regimens. And finally, for treatment-naive patients in genotype 5 or 6, there are 8 or 12-week regimens depending on other factors, cirrhosis particularly. But then keep in mind that all of what I've listed here are for treatment-naive patients with these genotypes. If they've already been on certain treatments, there are other guidelines, and I encourage you to go to the national guidelines to sort of look at that and be familiar with that. But I think as clinicians, the big issues you'd want to be aware of is that recognize when a patient has Hep C, are they being followed by the appropriate clinician? Are they on one of these appropriate regimens? Are they adhering to that regimen? Are they tolerating it well? Are they completing the full duration of that regimen? And are there any potential interactions with the drugs you're using that affect that regimen? There aren't too many drug interactions that are major that we as clinicians see when we're using other drugs for these patients, but you do want to run that interaction check to make sure there's not a problem. And finally, the areas where we expect you to recognize dosing is listed here.